Welcome to LOA Today. I'm Walt Thiessen here with Daniel Mangina. Today is Thursday, May the 14th, 2020. It's 5 p.m. New York time, kind of an unusual time for us, but wherever you are in the world, thank you for joining us for another episode of LOA Today, your daily dose of happy. And we're really happy because there's a reason why we're doing this at a different hour today. We have a special guest with us who is an expert in an area that I am really, really interested in. And that's why I reached out to her, and she was kind enough to agree to come onto the show because, Daniel, you and I have talked about this before. You are a fan, of course, of Dr. Joe Dispenza, who has taught people on a public basis about placebo and nocebo. And we've talked about that a bit here on the show. We have an expert here who studies this stuff. I mean, she's actually doing a study right now regarding COVID. I mean, it's just amazing. And so we're going to get a chance to find out, all about her and what she's doing and why she got into it and why she finds it exciting. So Dr. Luana Colloca from the University of Maryland, she's an MD and a PhD. And how many degrees do you have anyway? I mean, I saw quite a few there, but I'm not sure how many you've got.
To study, so that's why I collect a few degrees. Yes.
Okay, but welcome to the program. Thank you for being here. We really appreciate it. And I guess I just have to start off with the most basic question of all. How on earth did you get involved and interested in studying placebo and nocebo?
Well, first, thank you for having me, and thank you to those of you who are listening to us today. So I got interested in placebo by serendipity. I degree in medicine, and after completing my training as a physician, I realized that working with patients was very rewarding, but in terms of curiosity for the brain and intellectual needs, I was wishing to continue to study. So I started a PhD in neurophysiology at the University of Turin with Fabrizio Benedetti, that was and is a world leader in placebo effects. So I started my training as a PhD student, telling my mentor that, I'm a physician. I needed to do things that are relevant in medicine. And at that time, that was in 2002, my mentor had several projects with intraoperative surgical procedures. And that was how I started. And I used to say that it is a sort of epiphany because when you see some neuronal activities changing as a matter of belief that you are receiving a drug that eventually can change some symptoms, become very, inspiring. And I continue to do this kind of research until now.
And of course, I know you can't talk about it in any detail, but you're currently pursuing a study of placebo and nocebo where COVID-19 is concerned. And when I saw that, I was just blown away. Like, oh my God, this is like really, really current stuff. Can you talk at all about what made you want to even study that?
Well, I can't say too much for obvious reasons, but
Sure.
Many of you may have perceived some level of anxiety and distress when we start the distancing. And, many people start to feel symptoms that are not exactly the symptoms that we expect as COVID-19. Mm-hmm. And the symptoms that the CTSA are, communicating to the large community of Americans. So we start to realize that expectation, and in particular negative expectation, the fear of being infected might have a role. And many symptoms were merely nocebo responses and no rather related to any encounter with patient affected by COVID-19 or being infected by coronavirus. So that is why we start to do some kind of research, but now we are working more with COVID-19 and pain patients. That is one of the main areas of research of my lab, and I can't say too much about that, but we can talk a couple of months and I will have findings for you.
Well, and we're going to be looking forward to that. I'm going to be keeping track of when you finally are able to release some information, and we'll have you back to tell us about what you discovered. I'm sure it's going to be fascinating.
This is a team effort involving many people in the lab and some other colleagues that help with that.
Okay. All right. Very good. Let's talk about placebo and nocebo more generally. because I still think they're really interesting topics, especially with what's going on today. In my admittedly limited study and understanding of the topic, from what I can see, mainstream medicine, first of all, doesn't really give a whole lot of attention to it. And to the degree that they do, it seems like most of it is about, well, you can use it as a painkiller, and that's about it. Is that true, or has science gone further than that?
Well, that is not completely true. I mean, you ask me why I have all these degrees. I mean, MD, PhD in neurophysiology, and a master in ethics were, you know, collected because I felt I needed to learn more about placebo and how the placebo research expand from a laboratory setting where we study, for example, relief of pain to clinical trials. I mean, and again, we talk about COVID-19. Now, many people believe that certain drugs can be efficacious. We even hear people drinking iron alcohol to treat COVID-19 symptoms, and they end up dying. So placebo bring the rigor of methodological approach when we need to validate a new treatment that can be a pharmacological treatment or a non-pharmacological treatment. So that is how physicians and people working in medicine and science usually understand placebo. So we simulate a treatment, so people expected to begin treated. In reality, they can receive a sham pill, a sham surgical procedure, and this kind of mindset around the treatment can produce a benefit. This is one context where we can use placebo knowledge and research. Another important context is laboratory research, neurophysiology. How can we understand the mechanism in the brain and functions of the brain that so far we didn't focus too much, and try to understand which kind of networks, circuits in the brain can reduce pain symptoms or some other symptoms from nausea, Parkinson, and many other areas of medicine. So that is what we do in my lab. We try to understand the mechanism underlying placebo effects from a neurobiological approach. This includes genetics, this includes brain imaging, and psychological and behavioral responses. Why do we do that? I mean, as a neuroscientist, I like to learn about the descending pain modulator systems. To do, an example, if a person receives a treatment, a patient in pain, and eventually this person starts to feel better, we want to know which kind of mechanism are playing. And this can be in part, systems in the brain that are related to treatment targeting specific part of pain processing, but also related to expectations. So, and this kind of approach is revealing new mechanisms in the brain, in the body to heal. So somehow this is a sort of, advancing our knowledge of brain functioning. And another important approach is how patients can improve by learning about this knowledge. And that is a very broad area of research, more clinical oriented, where we try to learn from knowledge we gain in the lab to improve the way we communicate with our patients. We provide, therapeutic options, and also sometimes.
Okay. So I'm going to ask you a question that you may not be prepared to answer based on research that you've done so far, but I'll ask anyway. Is it reasonable to believe that people can literally heal themselves by believing they can heal themselves?
We see that so many times with patients, and that is one of the reasons why I like to study the neurophysiological mechanism of placebo effects. I feel a little bad to share stories, but I can be vague enough.
Sure.
We had a patient come to the lab that arrived with a long list of pain therapeutics. And eventually we use our procedure, and our procedure, induced an analgesic effect that was extremely, relevant. So the people who starts to feel no pain. And this no pain, as you can imagine, was related to a manipulation that entailed this mechanism of placebo and expectation. So we have also the opposite. There are case reports in the literature of patients who feel extremely worse or bad to the point to run to the ER, believe of experiencing fever or other symptoms when in reality was merely a nocebo response. And there are cases described in the literature of symptoms that require an intervention to make people feel better, when in reality there was a randomization to a clinical trial where patients, instead of receiving antidepressants, they were receiving placebos, and they eventually try suicide with a bottle of placebos. Yet they felt, the drop in blood pressure and many other symptoms that require an intervention for these patients. So yes, the mindset, the use of placebo can become, a therapeutic tool sometimes to improve, different conditions. And with that, I would like to stress that placebo can never replace active treatments. What we like to emphasize is that placebo is a component of any treatment. So if I'm taking Advil to treat, for example, some muscle pain, the expectation of improving when I take Advil make me feel immediate relief, when we know that eventually, the pill from the mouth to reach the stomach and eventually to be metabolized requires some time. So this feeling of feeling better immediately, this is what placebo effects is. And we know that sometimes it's really needed to boost the action to an antidepressant, to anxiolytics, to antidopaminergic drugs, and so many other treatments. So it's a sort of positive component that somehow, by activating specific mechanism in the brain, can favor a response to a treatment that is active and not merely sugar pills.
Okay. Well, then let's take it a step further. Is it not only possible? Is it something that actually could become part of regular doctor-patient relationships, where the doctor actually starts stressing you can heal yourself? Is that something that's on the horizon, or is that further down the line?
Patients love to be informed, and physicians have a duty to inform their patient. So instead of use placebo in a deceptive way that has been done since medicine start. I mean, it's part of the history of medicine, the deceptive use of pills and medicines. We are a step forward in 2020, where patients really like to learn about this kind of phenomenon. The fact that they can activate healing mechanisms that are part of our ability to heal. At the same time we heal from injury, a wound, we can also contribute to the healing process with having positive expectations. So as part of my work, I've been moving from the lab to more theoretical, philosophical, and ethical perspective, where we try to reframe the way we communicate with our patient and the way we consider the interaction between patient and physicians, clinicians. So it is very important to acknowledge that today patients are very much informed, that they are open to learn about new aspects of medicine and healing. And I definitely encourage any physicians, any clinicians to explain that our brain has per se a set of mechanisms that can help healing. And this kind of conversation can be done in a in different way. We can even think about tools to educate patients about this kind of effects that can be positive when we have a positive expectation, or also detrimental with negative expectations.
Okay. Well, you're encouraging the way you're saying that. And I'd like to hear more about some of the things that you've been able to discover are the more effective ways to help patients get into that frame of mind? Because you kind of alluded to the idea that you kind of change the way that you communicate to the patient.
I can give you an immediate example. All the patients that come to my lab, they know that at some point we use deception. And before we start any procedure with them, as part of the informed consent, we tell them your participation in this study entails some level of misleading information and deception. So at the end of the study, we communicate with them where eventually in which part of the procedure was misleading. And they love to learn about this phenomenon. But we also study, nocebo effects and communication of side effects. How can you inform patients about, serious treatments and related adverse event side effects? So we have been exploring together with some other colleagues that, for example, providing a checklist of side effects produce a different impact in the perception of getting worse from an information like, tell me if you know something different than usual. So even a structural approach to getting information related to side effects of treatment can be very informative and help patients to experience less side effects. And what we emphasize is mostly framing effects. You can tell patients 10 out of 100 experience these specific side effects, or 90 people do not experience these side effects. You can use cartoon, you can use example. So, and of course you need to tailor the language, the communication to, the patient needs. That can be, a different need related to psychological factors, but also education, cultural elements. So that is all we emphasize when we talk about clinician and way they inform their patients.
Now, there's another interesting piece of the placebo side, interesting to me anyway. Again, Dr. Joe Dispenza talked about it in his book, You Are the Placebo. He talked about how, yes, in most cases where placebo is being introduced into a therapeutic system, so to speak, it is usually on a deceptive basis. But he's also pointed to cases where the patients knew in advance that they were being given placebo and it still had the effect. Have you explored that side at all?
Oh, absolutely. That is what we call open label placebos.
Okay.
So the open label placebos is relatively new area of research, although I have to say Park and Cove introduced this in 1960 at Johns Hopkins, where first they had the idea to provide open placebo to patients with psychiatric problems. And they were telling patients, you are receiving a placebo, and yet they observe a benefit. From this sort of anecdotal use of placebo given transparently, and we move forward to more rigorous science. And the approach has been at different laboratories where they provide placebo. They inform the patient, okay, this is your bottle of placebo. They write placebo on the bottle, or whatever placebo treatments they use. But also they have this educational component. They inform the patient the reason you may feel better is because while you take a pill, we have a series of mechanisms like classical conditioning, like Pavlovian dogs, that trigger subconsciously some mechanism of healing that may make you feel better. And this kind of approach of informing patients you are receiving placebo on top of your treatments, for example, pain therapeutics, has been used in several pain disorders as well as non-pain disorders. One of the most relevant studies was conducted at Harvard, where IBS patient with irritable bowel syndrome receive a bottle of placebos to be used on top of their dietary and other treatment as needed, merely adding for a couple of weeks a placebo on a daily basis made these people feel better. Some of them start again painting, enjoy life. So, and since then, we are truly trying to understand what is behind that. Why do people respond to open placebos? So
Sure.
we even interview this patient. Did you understand? You are getting an inert treatment. This is a pill made with, sugar, talc, and so on. So they do understand. That is why I feel like we are really moving forward from deceptive research around placebos. Doesn't make sense to, invoke the deception component of placebo anymore, because even this sort of paradoxical approach where you use open placebo makes people better. So
It's a remarkable thing. And it's one of the reasons why I am so interested. I know Daniel's interested too. He's a big follower of Dr. Joe. It's fascinating. I'm wondering, do you think there are limits to how far placebo and nocebo for that matter can take us in terms of, treating dread diseases and so forth? Are there any limits, do you think?
absolutely. There are diseases where we can't even think about using placebo, like cancer patients or some other serious psychiatric problem, schizophrenia, major depression, and so on. I mean, I hope none of the clinicians listening to us take us message that we can use placebo to treat some kind of problems. No, absolutely not. So placebo have some limitations, but the placebo effects per se, where we move forward and above any placebo, can be still relevant to any kind of problem. A cancer patient can survive, or at least live a better quality of life if the expectation is positive, and we do know that. And also we know of many patients that are told you have 3 months life expectation, and somehow they set their clock to live that time. Or some other patients so resilient that say, no, I want to make this up to the end of this year, and they continue to be able to do that, even if the most charismatic physician suggests that eventually they have 3 months life expectations. That is why we truly believe that placebo components and placebo research can help re-understanding how the brain can influence outcomes. And that is what we love to do. I mean, we often do not even use placebo in investigating placebo brain mechanism, because we know that you are the placebo, the physician. The words that we use can be a sort of trigger for this healing mechanism that we have.
Okay. Very interesting. I could be asking questions all day, Daniel, but you may have some too. Do you have something you want to jump in with?
Well, first of all, thank you. It's great to hear from a purely scientific background. Let me pivot. I think sometimes we see, unfortunately, scientific facts being manipulated in order to sell spiritual stories. Walt's mentioned that I follow the work of Dr. Joe Dispenza, who, although is a chiropractor by doctorate, has spent time studying the mind and recording the evidence of what he's been doing with the meditations and stuff. But it's interesting that we had to make that caveat about the limits of placebo, because I personally know people that have used the placebo to deal with more serious things. So I was wondering where the line is drawn. Like, how do we define the line of where we say, okay, no more placebo now, let's look to traditional medicine, versus placebos up to this point? I know you mentioned some very serious conditions, but is there a way that we can say, okay, I'm going to use a placebo up to this point, but after this point, I'm going to try something else?
I think evidence-based medicine is the answer. I mean, we know that there are conditions like pain that can benefit from non-pharmacological approach, but there is, esthepathology of pain that is very important to be treated with, conventional treatment. With any physician working in the area of pain, I refer to pain because it's what we do, should know both part of medicine, complementary and integrative health medicine, and pharmacological approach to see how they can complement one another eventually, or when you truly need the pharmacological approach, but also when you truly don't need the pharmacological approach. Because one of the challenges to try to understand why some patients respond to a treatment and not necessarily a placebo. You know, we have patients that they try any kind of pain therapeutic, from you know, cannabis to opioids, and they still are miserable. Their pain doesn't respond. And some other patients that you know, they manage to have a health lifestyle and to cope with pain without pharmacological approach. So it is very important to not generalize. Pain patients are unique, and also the patients are unique. So it is you know, really the responsibility of the physician to try to understand which kind of disorders and etiology is in front of him or her, and make an informed decision where eventually a treatment needed to be stopped or a treatment needed to be introduced to make life of this patient better. And unfortunately, it's a little bit like being a politician. Some people draw these walls, you know, either pharmacological or non-pharmacological approach. And this, unfortunately, it's not for the best of our patients, because we need to be able to see the spectrum of therapeutics and be able to judge based on the needs of each single patient.
I love that completely, because I agree with you. I'm sure Walt will agree with me too. This simplification, I think, is dangerous, because you get, there's for example, there's a number of people just dealing with the cancer question. They say, oh, you know, this diet is going to fix your cancer, but then there are people that were already on this diet, that type of diet, that got cancer. And there are people that smoke 100 cigarettes a day and never get lung cancer. So there's more to it. And for me personally, I believe the work you were doing with the mind is that connective tissue, because my personal belief is that we can only step into something if we believe it's possible. And when I look at placebo and nocebo on a very, very rudimentary basis, we're looking at what we accept and what we reject, and seeing how that affects our physical world. So it's good to hear someone from the world of science.
That is why we challenge a little bit the understanding of placebo. In 2004, we start, you know, emphasizing that the placebo is a component of any treatment. And you study placebos and placebo mechanisms without any placebo. So we started to study placebo component related to morphine administration, to deep brain stimulation, to, you know, diazepam. So we target 3 different areas of medicine: pain for morphine, on opioids, or you know, anxiety, situational anxiety for diazepam, deep brain stimulation, that is a surgical procedure for Parkinson. And we didn't use any placebo, rather at the University of Turin, you know, we were exploring how, you know, merely being aware of being treated can make a difference. So for example, if we were studying Parkinson, we turn on and off this deep brain stimulation, that is merely a battery that is allocated in this area of the body. And the goal was to try to understand how the mind per se can influence the response to deep brain stimulation. So patients who were off, but they thought that the battery was on, continue to perform and be free to move and released from the Parkinson's symptoms, just as a matter of being somehow expecting of being treated. The same for morphine, you know, post-operative pain, patients treated with morphine in a hidden way, IV, or some other patient who were told, now we are injecting morphine. So those who were told, now you are about to receive morphine, immediately had the pain released. But those patients who were also told, now they start to feel pain. Those patients who were not informed, now we stop the administration of morphine, continue to have the pain relief as if they were treated with morphine. So you can see explore placebo effects is sometimes merely exploring expectations, and you don't need any placebos. The same when any patient receive a treatment that can range from an antibiotic to a painkiller. Eventually, the expectation of treating an infection versus treating pain symptoms can help patients to respond to the active treatment. So and that is the way I like to approach placebo effects. I'm not a scientist of sugar pills. Rather, understand, what is behind that and why eventually this interferes so much with our ability to treat patients.
So really, sugar pill or saying that we're turning something off or injecting a saline solution, what we're doing there really is presenting a tool for the mind to accept that something is going to work. And then there's a physiological response. Am I understanding correctly?
Correct. So when we have an expectation that a treatment, and we can remove the placebo as an example, a treatment is going to work, this can trigger a set of mechanisms in the brain and the body favoring the response to that treatment.
So anything and everything can be a placebo or a nocebo. Yes. It really is about our level of certainty and belief in the efficacy of it.
Exactly.
So even in conventional medicine,
I would like to emphasize that many placebo effects occur not because of beliefs. I can also do not believe that acupuncture or an open placebo or an active treatment work, and still there are a set of subconscious mechanisms whereby merely taking a drug can help a patient to feel better, because we trigger, especially in the context where we have awareness about the expected outcomes, that starts to have a critical role. And we call this learning mechanism, conditioning mechanism, subconscious therapeutic effects, where merely taking something play a role. And this something, again, can be the active treatment, but also going to the physician. I mean, how many patients start to feel better once they enter the room of their physicians? That is why you are the placebo. There are all this sort of a complex around any treatment, around any interaction with our providers that eventually can trigger these mechanisms. And this is well known by, different physicians. Some are taking advantage of this kind of aspects of a human being, and they are charismatic physicians. Some other do not are, so skilled with that, and eventually they tend to be less successful, not because they know less, but because of this lack of interaction and ability to use competence, expertise, and warmth as part of the therapeutic interaction with their patients.
Which is very important, yeah. What do you think it's going to take for more physicians to start adopting it into their practices on a regular basis?
Well, I was trained as a physician, and I remember that I had a couple of hours of training about communication and empathy, but until you see that as only a moral, ethical requirement, you tend to, prioritize other aspects of medicine and the training. When you start to think that behind this interaction between patient and provider, there is a sort of biochemistry that eventually some trigger and activate. Probably you may start to have a different role. Some other physicians and clinicians are by default skilled to use that. They like to engage. They like to, but we are not really trained as physicians to do that. Not yet.
Do you think it's going to happen? Are we going to start seeing physicians getting that kind of training as part of their overall?
I know that some colleagues of mine in Australia are, doing simulations where they change the amount of warmth or the amount of competence that a physician can show to a patient before entering the surgical room, and this can per se can change the perception of pain post-surgery surgical approach. So there are some scientists that focus on that, but usually for things to translate from science to clinical practice may require a little of time. It's not something that may occur immediately, although this kind of knowledge is appealing. Reporters, patients like to hear about this.
Sure.
Absolutely helps disseminating, what we discover in lab, and eventually reach out to providers to improve their ability to, interact with patient.
One of our regular live stream listeners has sent in a question. He's asking, can you speak about the role of placebo in treating psychosomatic illnesses?
Well, I was hoping not to receive this question because sometimes it's controversial how much of psychosomatic disease, but also non-pharmacological approach depend on placebo effects. So we definitely know that psychosomatic disease are heavily modulated and shaped by our mindsets, by our expectations, and especially negative expectations. An asthmatic patient who smell a flower that eventually is a fake flower can have an attack of asthma because of expectations. Some other people are less vulnerable to this kind of responses. So the psychosomatic component is definitely important. Some people may feel better because of that. Some people may feel worse because of that. So it is a component that in part may rely on placebo and nocebo mechanisms. But we don't have a lot of science about that. I mean, if you do a search of the literature, there is literally so little about how placebo and nocebo mechanism play a role in psychosomatic medicine. So why I don't have an answer, but probably expectation definitely play a role. And it will not take too much effort to introduce a sort of systematic approach to psychosomatic medicine and adding the evaluation of expectancy or expectations to try to understand to what extent this can be part of the picture.
It's fascinating. We're kind of at the early stages of the development of this as a science, aren't we? I mean, placebo for the longest time was something that was just something to be discarded and to be ruled out when you're trying to test out a new drug. And it was never really taken seriously until, 20 years ago, something like that, 30 years ago?
Well, we start with the example of clinical trials. How can we validate a new drug without a placebo arm? So this continues to be an urgent need. Now that thousands of clinical trials fail because drugs do not outperform placebos. So definitely we need to improve our clinical trial drug development approaches, and placebo research can inform that. In several ways, we can have new strategies to design a clinical trial where new designs can help to tailor to what extent the placebo responses can influence the outcomes. But also a big question is why some people respond to placebo and treatments and some other people do not respond. So that is one of the main challenge. This is the main line of research in the lab now, where we try to understand to what extent genetic brain mechanism can help us to understand why some people respond to placebos and some other people, no matter which kind of manipulation we perform or no matter which kind of treatment we provide, they continue to be non-responders. So that is the challenge, and I can explain why. Somehow, if we can predict those patients who respond to a placebo in the context of a clinical trial, this will help drug development because eventually we can understand if a new drug under investigation can be beneficial or not. Another important approach is what we call, precision, personalized medicine. If we know in advance when a patient enters into the office, okay, this patient is a non-responder, we can think more carefully about the therapeutic strategy as compared to another patient that can go home and probably benefit from lighter therapeutic treatments where we don't need to invoke several, pain therapeutics because these patients somehow are, less vulnerable, and this kind of ability to activate this, chain of mechanisms in the brain, in the body, can help them begin treated with less side effects from standard therapeutic approach. So that is the main question. How can we identify those people who are going to respond to treatments and activate placebo mechanism as well, and those who are somehow more difficult to be treated?
Mm-hmm. There's a lot of work to be done here, isn't there? And not a lot of people are doing the work that you do. I mean, I'm certainly no expert on who's involved in the field, but my limited research has revealed something like less than a dozen people who are involved in doing this kind of research. We're not talking like thousands of people who are doing this kind of research.
Well, it depends. Again, if we consider drug development, everyone is involved with placebo. There are a few studies that do not include a placebo arm, like cancer-related clinical trials where somehow it's not acceptable to use placebo, and some other clinical trials. So in drug development, placebo are still the gold standard as of today. So since the last 70 years, they use placebo to try to validate new drugs. In terms of neurophysiology of placebo effects, neuroscientists that look into the mechanism of, placebo effects, probably we are not so many, but yet there are, different labs in the States, across the world, in Europe and Australia and so many other countries that, we're a small community, definitely. We know one another, for example, but
sure.
I can tell you that the amount of interest and is raising new scientists in the area. And I'm an educator, I'm a mentor. I see, it's part of my past students, my new students that eventually will end up continue with creativity, this line of research. The important thing is that we understand the mechanism and we try immediately to translate to clinical practice. We don't need 5-10 years before we can see these things translate to, some specific area of medicine, and that is positive. And another interesting component is that as part of, neuroscience, there are some people studying fear, some other people studying expectations. So it's a subtopic within the large umbrella of neuroscience and clinical neuroscience.
Sure. Yeah, and the stuff that neuroscientists are studying is really becoming quite fascinating. That's almost kind of blossomed in its own way. The whole umbrella of neuroscience is just kind of, over the last 50 years, it's just kind of taken off. And 50 years ago, it was almost unheard of. Now it's like it's a major component. So it shows how a new branch, so to speak, can just kind of take off. I want to bring up somebody else who I found. She's a medical doctor, and she has written some books on the topic of placebo nocebo. And she posted an article in the last week. I'm not sure exactly when it was. And I'm going to kind of be risking a little bit because I know you have your study that you're doing in regard to COVID, and this does address COVID. So if there's anything you can't talk about, we'll just stop. But I'll ask anyway. It doesn't hurt to ask. That's the way I'm looking at it. She wrote an article in which she came up with a list of 17 questions that she thinks ought to be brought up just to explore the current approach that's being taken by what I'll broadly call mainstream medicine to deal with COVID. questions that are she's just seeing in the information that's been put out, that's been published, that's been put into the journals and so forth, that just kind of raise questions in her mind about what are generally presented to the public as, well, this is what we know, this is what we do, this is what we advocate. And there were a couple of them in particular I wanted to ask you about. The ninth one on her list, one of the things that she's kind of challenging is that in her words, the scientifically proven nocebo effect is not amplifying what might have been a relatively benign outbreak were it not for a media-driven pandemic of terror and fear, which is a very passive-aggressive way of saying, hey guys, how about nocebo? Again, I don't know if you can address this because of the study you're doing, but can you talk about that at all?
Well, I challenge all of us who didn't experience anxiety or fear at the beginning of the pandemic. I mean, it is quite normal to perceive some level of anxiety, situational anxiety related to the pandemic, as well as fear of being infected. So it is very difficult to draw the line here and try to understand what is a nocebo effect versus what is a sort of acceptable level of fear, anxiety, and distress related to the pandemic. We know that COVID-19 is a serious disease. We know that as physicians, we have a lot, to work towards, strategies to treat the disease and prevent the disease with a new vaccine. But definitely, in terms of what we call mass responses to the pandemic, we observe a certain level of anxiety, and we can call nocebo a person who experiences, the different symptoms that somehow are similar to COVID-19, but with a negative test or no fever. So many people under the stress of the pandemic may have experienced some level of nocebo responses in show COVID-19-like symptoms that in reality were not COVID-19 related. So to that extent, yes, there was a nocebo response. And I tell you, I was contacted by a different colleague of mine to write something on nocebo. And I decided to stay away for a personal, moral, and ethical matter, because I do believe that to some extent is physiological and, acceptable that some patients manifest and present with a certain level of anxiety or fear. But rather than, somehow target and label that as placebo or nocebo, you should provide the tools to people to be able to say, see, you're negative, you did the test, or your symptoms do not escalate to the spectrum of COVID-19 symptoms that we know. So the best response is to help them to, relax, breathe, and realize that despite the challenge, it doesn't mean that any person has COVID-19. Rather, COVID-19 continues to be a serious condition that can be easily separated by nocebo responses at this stage, because we don't have a nocebo responder intubated and or end up in the ER, but we can provide the people with thermometers to check the temperature, with a treatment to psychological treatment to manage their anxiety and their fears, and to try to contextualize that it is okay to be fearful, but do not let our, somehow mindset drive us to the level to begin nocebo response and see some symptoms that can make us feel somehow bad. I hope that any clinician was able somehow to help all this kind of patients that somehow felt sick without being exposed to the virus. So I think it's part of the challenge, having some sort of nocebo component as part of the pandemic. But yet the pandemic is so serious that I don't see a real worry for the nocebo part in this case.
And probably that is a challenge that all physicians are dealing with one way or another, regardless of how much affinity they have for the placebo nocebo concept. Where do they draw the line on what treatments that they're doing? How do they decide where to go? It's not like there are straightforward protocols that have been worked out, because they're working out the protocols. They don't really know yet.
Sure, but although we don't have a straight protocol, there is enough out here. And this, we know that the proportion of patients who become very severely affected by COVID-19 is not the majority of the patients, it's a portion of the patients, still very relevant. And a clinician, a physician who has minimal knowledge and is following what the literature is putting out can see that there are strategies to help the majority of the patients who encounter the virus. So definitely, I don't see the challenge in drawing the line between placebo or nocebo responses versus person who is experiencing COVID-19 symptoms. I mean,
Okay.
Again, I feel like to some extent having some kind of nocebo responses in this case was even positive, in the sense that some patients can be a little more cautious in distancing, stay at home, and do all the necessary, precaution to avoid to infect other people or avoid to be exposed and begin infected. So it is this situation where you want people to be a little fearful so that they can take this seriously. Because how many people continue to say, oh, this is just an influenza, this is a common cold. I mean, we know that that is not the case. So that is a beneficial nocebo response.
Okay. So an argument in favor of that.
This is my opinion. Some other colleague of mine may have different opinions, but that is what I feel.
Well, that's the nature of what we're dealing with here. I mean, physicians themselves are still feeling this out. There's a lot yet to be learned about it. So, you have to kind of make your own determinations as you go along when you're a physician.
Physicians and clinicians need to read the literature. I mean, every week we are greatly informed by standard journals that they release even the publication fees to allow everyone to read about the protocols that have been used in different countries in this country. So you have to find time in the evening instead of watching TV to read the 3, 4, 6 papers and see what is out, because literally we are bombarded with new informations, things that before we thought that may be beneficial, now we know that are not beneficial. So it is very important to be on top of the literature so that you can really make informed decisions about the treatment of your patients.
Right, sure. Yeah, because these are important decisions that they're making on a day-to-day, hour-by-hour basis. And so absolutely, staying on top is really important. Yeah. Let me go in a slightly different direction here with the idea of I'm not sure how to even go here. Give me a moment to formulate my thought. Where I'm trying to get to is placebo and nocebo as a preconceived mindset before the patient goes to the doctor. In other words, to what degree does the mindset of the patient before they're even seeing somebody play an important, or perhaps it doesn't play an important role in whether or not placebo or nocebo is going to come into effect?
We call this anticipation. So before we eventually encounter, meet the provider, we read online, we Google, we talk to our peers. That is one of the relevant line of research. We received recently a grant from the National Center for Complementary and Integrative Health to try to understand again the brain mechanism underpinning this ability to have a sort of information related to observing another person. We know that human beings learn a lot by observing. So if we watch someone feeling better because he or she received a particular treatment, we activate in the brain specific mechanism that our lab is discovering. We publish already, we show that the theory of the mind can be so relevant in mechanisms that allow our brain to simulate this outcome before we are even being treated. So, and this is so relevant today, and even during this pandemic, where we learn a lot from, this sort of social media and informing one another. So that is why it can be relevant, to understand that patients today are so informed. So physicians should be careful in exploring, okay, what do you know about the disease? How do you expect your symptom may change as a matter of treatment? And ask two simple questions. What do you expect? What do you know about this symptom, this disease? Can help any physician to tailor a fruitful conversation with their patients and try to understand what is true and what is less true. Where are the fears, and rather where are the areas that eventually you can do some educational component together with the diagnostic and therapeutic approaches.
Mm-hmm. Very good. Okay, Daniel. Before we cut the cord here and send Dr. Colloca on her way, do you have any last questions you want to ask her before I do our little promos?
I'm actually really happy. It's been great to see science that opens up to see the possibility of miracles, but gives us grounding so that we don't get lost in the fairy dust of miracles and tap those to create real results. I want to thank you for your work. I think it's great what you're doing. You're a credit to medicine, and we really appreciate you coming on today.
Thank you very much for having me. It was
love it.
fun to talk to you.
Yeah, it's been great.
Yes.
I just want to remind people who are not yet subscribed to the podcast to become subscribers. I mean, this is the kind of great content we try to give you, and we do it to help you feel confident in all areas of your life. In this case, we're talking about health, but we try to do it with all areas of your life. And most of you are subscribers. We do appreciate all of you who are subscribed and who regularly listen. Dr. Colloca, you wouldn't believe how loyal our listeners are. I mean, they're really, really great people. But for those of you who have not yet subscribed, go to the homepage of our website, loatoday.net. You'll find instructions at the top of the page on how to subscribe and get all of the episodes that we do 5 days a week here on LOA Today. Also, you can check us out on YouTube. We are live streaming this today as we usually do to YouTube, so you can check us out there. You can see what Dr. Colloca looks like in her office and so forth. But it's a great way to find out who we are through vision as well as through the voice. So feel free to check us out there. Just do a search for LOA Today podcast videos, and you will find us there as well. So, wow, this has been great. I mean, I almost feel overwhelmed. You are clearly an expert in your field. I mean, I have to admit, I didn't really expect the detail.
I love to study. I love to study. So.
You're very good at it. You are extremely good at it. It's evident. It's obvious. And we really appreciate you taking the time to share your expertise with us. I will be following up. I'll be watching you. I'll be listening for when you're ready to release results on the study you're doing now, because I'm really intrigued by that. And don't be surprised if I reach out to you and say, hey, come on to the podcast and tell us what you found out. Okay?
Will do. Thank you.
That would be really wonderful. Thank you again for coming on. We really appreciate that so much. Also want to thank live streamers who were able to find us at this 5 o'clock hour. It's kind of unusual time for us, but you were able to find us. Thank you very much. Thank you also to our podcast listeners as well. We'll see you all next time here on LOA Today. Goodbye, everybody.